Welcome to the Health and Wealth Power Hour, the podcast that provides you with the knowledge and insights you need to achieve physical, mental, and financial well-being. I'm your host, Harlon Pickett, a business consultant who's passionate about helping people achieve a more balanced and healthier life. Each week, we'll deep dive into topics related to health and wealth, including retirement income planning, innovative healthcare solutions, alternative funded health plans, and specific actions individuals and business owners can take to gain control of their finances, have access to affordable quality health care, and achieve peace of mind. We'll also be joined by innovative experts who will share their knowledge and insights on prevalent topics. So, whether you're looking to grow your wealth or improve your health, you've come to the right place. Get ready to be informed, inspired, and empowered. Let's get started.
Well, now, here we are again. It is time for another Why Does Healthcare Suck? I'll tell you what, it's been a lot of fun really sharing some of the reasons why we have such a difficult time in our country with healthcare, but I sure appreciate those of you that are coming back every single month. We certainly had a great time last month talking about healthcare horror stories. It was very insightful to hear some of the folks that got up there to talk about their own stories, things that they had been through. So it was really, really good. All right, so let's go ahead and get started. You know, we are super, super blessed today to have a subject like fee for service that is the whole United States healthcare. That is what it's all about. And when you think of fee for service, it typically is because of the way things are paid for. The structure that allows for providers and physicians to receive payment in this country is the fee-for-service model. Now, what that looks like is typically, where does that payment come from? Insurance companies, government agencies, or other third-party providers, they're paying for the services that patients receive. This is why, interestingly enough, all of your big insurance companies are called payers. But whose money is it? Well, it's not really their money, is it? It's really our money. It's those of us who have paid their premiums. It's our money, but they are considered the payers in this case. In fact, as I was going through and preparing for this, I could really only find one huge pro, as it were, when we're going to talk about the cons today. And we got someone great to do that, and I'll introduce him in just a moment. But I can only find one big pro for fee for service. And that is if you were actually eliminating those exact entities, that middleman, whether it's the insurance companies, the government agencies, or those other third-party providers. If you got rid of those, fee for service worked pretty well. Why? Because now you're cash pay. Now you're paying on your own. Oh, wait. That's a free market principle. That's the same thing we're preaching already, is free market principles. So fee for service does actually work if you're paying your own bill. If you have the money, which, hey, that's a big deal today in the healthcare arena, right? If you have the money, that means you can go wherever you want to. There's no limitations. If you can find someone that wants to see you, provide the services that you need or that you want, and they're willing to accept whatever you've agreed to, or you're willing to pay whatever they say they're going to charge, fee for service works great. The problem becomes when you start introducing the middleman. And talk about that and many other parts and cons and the overall effect that fee for service has had on this country's healthcare. We are extremely honored and blessed to have Dr. Clint Flanagan with us today. He is the founder and CEO of NextEra Healthcare, and a huge proponent, obviously, of DPC model. He has spread that word across the country and has a number of clinics in various different states. I was very lucky to talk to him at the HINT conference in San Diego earlier this year, where we started the conversation about what this would look like. And so, Dr. Flanagan, thank you so much for being with us to talk about this important subject today.
Well, really appreciate it, Harlan. Looking forward to the discussion, and hopefully everyone will come away having learned a bit more about fee-for-service healthcare, or specifically fee-for-service primary care. I've got a lot of experience on that front as I've been familiar with it here in Colorado for over 20 years. So looking forward to the discussion. And I think, at a high level, it's about the doctor-patient relationship. And unfortunately, despite spending over $4 trillion a year, there aren't a lot of Americans that have an excellent doctor-patient relationship, and that's something that we need to fix. And so we're on that pathway, and it's part of the reason we named our company Next Era Healthcare, because we were not satisfied with the existing fee-for-service primary care system. So we said, hey, we need to move to the next era.
Yeah, and it's interesting that you put it that way. I know we've had these conversations, and this is kind of a little bit controversial to say it this way, but so many people keep saying that, of course, our healthcare system is broken. And there's those of us who have really just kind of embraced the fact that it's not broken. It's actually working exactly the way that the people who designed it wanted it to work. And that's why so many entities out there are getting rich, and the American public is going broke and having bankruptcies. And when you really look at the root cause of that, it's because of the nature of the way our system is built. And they equate the fact these days that you have health insurance, that you're protected from that, and that you have access to health care. And that is simply not true. It has been proven over and over that that is not the case. But some of the root cause of that is because of the structure, this fee-for-service structure, that prevents you from getting the services that you may need. Well, we see it all the time, right? In the news nowadays, you see these huge impact of denials. I was just reviewing this with my team yesterday, that from 2022, from January 2022 until July of this year, there's been a 64% increase in denials from Medicare Advantage plans and a 20% increase in denials from commercial health plans. Well, that is unacceptable for people that really need to have some stuff done. They're not just flippantly throwing those things out there. And on the other side, they're in many cases going against, and I won't say in many cases, almost every case, they're going against the recommended procedures or treatment or whatever that has been given by the physician. So as we kind of go and unbundle this some more, Clint, talk about the inherent issues of fee-for-service. And I know why you created Next Era is to fight that. But talk about your personal experience and what you've seen and what really pushed you to change the game.
Yeah, kind of a lot to unwrap there. As you said, Medicare Advantage. So I don't even want to go down that rabbit hole too much, but us doctors kind of behind the scenes, we kind of call it Medicare Disadvantage. So that's a whole nother podcast. But as we think about primary care and then particularly fee-for-service primary care, as physicians, we go through years of training in medical school, and then you go through at least another 3 to 4 years of residency after medical school. So you're 7 to 8 years into training to become a physician. And I recall back in my last year of residency training, I think I had about 2 weeks of business. 2 weeks of the business of medicine, and so then you come out of residency and you're just excited to take care of people. And in my case, I joined a multi-specialty group of about 50 doctors where it was a private physician-owned group where everybody was partners. And very early on, you start to figure out that the way you get paid is through billing and coding in this fee-for-service primary care system. And so every patient essentially is a transaction. And the way the revenue flows is by billing and coding and stacking your clinic day to the point where you're seeing, let's say, 25 to 35 patients per day. And I did that for a number of years. And gosh, it's really hard to have the time and sit down and have a conversation with patients about everything from diabetes to high blood pressure to mental health issues when you've got 15 minutes, right? And then with that, you've got to bill and code for that procedure. So this is back in the early 2000s or so. And moving forward, we kind of had hoped that the Affordable Care Act would create a better lane for primary care in this country. And unfortunately, while it may have had good intentions initially, I think in the fourth quarter, you saw the insurance lobby come in and really change things up. And to give you an idea of how it benefited the insurance company, you just have to go back and look at the stock prices pre-Affordable Care Act and then follow that out until 2023. You'll see what I'm talking about. And so what it did, it created essentially higher and higher insurance premiums and more and more people on deductible plans. And these people on deductible plans, the plan maybe gives them one visit a year with their doctor, right? So it's not really care. And so, how did fee for service get started? I think it got started in the 1930s, and it was Blue Cross Blue Shield that kind of came into play and said, we're going to start paying doctors on a fee for service basis. And so decades of fee for service, let's say, and then you got into the 80s with HMOs and more fee for service. And what we know in general, what happens with fee for service primary care is it leads to overutilization of services. It leads to unnecessary procedures, and it leads to increased costs. And with all that, there's limited focus on patient outcomes and limited focus on quality of care. In fact, there's discussion on how it may even discourage preventative care and coordination among healthcare clinicians. So think about that. Like it's essentially like a disease state system where, it's not about, gosh, how healthy can we get you? It's about, hey, we can make a lot of profit off more and more procedures. Some of them maybe aren't even necessary, and sickness. And truthfully, a lot of us physicians went into actually healthcare and all this training to take care of people and to try and get them healthier, to try and really make an impact on their quality of life, right? And so back to coming out of residency, you're a greenhorn and you just really want to take care of people. And then what you find is that these things are getting in the way of that. So it was definitely a bit of trial by fire coming out of residency, I'd say. And over time, it unfortunately in the fee for service primary care world, it's kind of like death by 1,000 cuts. Right. And you have this continual moral injury that happens daily as a clinician because you see these things getting in the way of the doctor-patient relationship. And it is morally, ethically, and perhaps even arguably legally just challenging on a daily basis. Right. And then you have these people coming in with a third-party payer system. And the majority of people have no clue what their insurance coverage is paying for or not paying for. They come in and they think that insurance card is going to provide them care. And to be crystal clear, that insurance card is not care. In fact, I don't even like to call it health insurance. It's insurance. They're not in the business of health, right? And so you've got to find yourself a position and a healthcare team that you can have access to that's convenient and affordable, where you feel connected. And as I look at the chasm that has been created between physicians and primary care and patients, it's only gotten wider and wider in my 20-some years of being a family medicine physician. And part of that, as you may know, Harlan, but I'm not sure if all the listeners know, is so I did about 15 years of emergency medicine here in Colorado as well, working in rural ER emergency rooms. And boy, that really gave me a lens on some of the challenges in this country, because many people were coming into the ER to see me for issues that their primary care clinician should be taking care of. And most of these people didn't have access to their primary care doc or clinician. So that really, helped turn the light bulb on of saying, how can we do better for patients? How can we do better for physicians? How can we do better for our communities? And after years of being in that fee-for-service insurance-based primary care system, we said, gosh, let's just make it simple. Let's move to not using your insurance to try and pay for low-cost primary care, right? Like you'll hear us physicians in direct primary care talk about like, using your insurance to pay for low-cost primary care would be, the equivalent of using your auto insurance to pay for gas or pay for an oil change or pay for your windshield wipers, right? Like you would not do that. So let's stop doing that. And you have choices. So you have choices in 2023 as an American, and you do not have to continue to choose and or pay for that high dollar insurance card that unfortunately just creates a barrier between you and your doctor. You mentioned earlier about denials. Like denials are a profitable thing for insurance companies. And when I order something, I don't have to move through that detail of having to get a prior authorization for an MRI for a patient that I know needs an MRI. I don't have to waste my nurses and medical assistants' time, spending a half hour on the phone with an insurance company trying to talk to a person about getting a prior authorization approval for an MRI. Right? That's just a waste of time. And unfortunately, millions of Americans are still in that pathway, right? Because they and or their employer have a benefit plan, and it's questionable if it's even a benefit, right? Where they've got these challenges or hurdles in between care and appropriate procedures or appropriate imaging or appropriate labs.
Yeah, and you kind of touched on it there. The barriers are very real because of all the referrals that you have to go through. But let's say that you have one of those awesome, and hey, just ask somebody who has one. A PPO is awesome, Clint, because I can go wherever I want to, and I get this great discount on this PPO. I love that. I love when people tell me they have a discount from their PPO, because the first thing I want to know is, well, how much of a discount do you get? Oh, at least 50%. Okay, well, what was the starting price? 50% off of what? No one can answer that question. So how much of a discount is there if you don't know what the discount was to begin with? But when you start seeing these barriers, the price and the accessibility are some of the biggest parts. I know you hear the same thing. And one of the big differences about working or people that are in your model and your patients and all of your facilities patients and their access to you is they don't have to wait weeks or months to see you. And that's a huge deal, because that removes a huge barrier to healthcare. If I need to see a doctor, it's what you mentioned earlier. If I need to see a doctor, I want to see a doctor now. If I'm not feeling well, I want to see a doctor now. And otherwise, what happens? I end up in the emergency room, right? And boy, that bill's going to be fun to look at. But the people feel like they need care right now. And so they don't want to wait. But the worst part of it, we have a partnership with a group in San Antonio, Houston, and Austin that do a very interesting thing. They do exit interviews with people that will talk to them. And because it's membership based, similar to your clinics, people can go in and have all their services at zero cost, and there's no bill later. There's nothing else. So everything they have that's done right there is zero. So they asked the question, if you wouldn't have come here today, where would you have went? The most startling number that I heard was that 27% say they wouldn't have went anywhere. They would not have sought care. That is astounding. They would have just said, hey, let's rub some dirt on it, or let's just suck it up, buttercup, and hope that whatever this is goes away. They would have not sought care, Clint. That's not right, buddy. That's not right.
Yeah, I agree with you, and it's sad, and it'd be one thing if we were just spending a few dollars for that, let's say, lack of service or level of service, right? But we're not. We're spending a lot of money for that, and I mean, we specifically employers and employees. And so if you look at this is per Aon. In 2023, an employer on a plan is paying around $11,200 and some dollars for an employee, and the employee is paying around $2,600 to $2,700. So you add those two numbers up, it's about $13,900 is what an employer and employee is paying for a insurance premium, and that went up about 4 to 5% from last year.
Right.
So you mentioned earlier that, that could be, let's call it the Cadillac PPO plan that offers fee-for-service primary care, right? And you as an employee want to go see a primary care clinician in that plan, where you and your employer are paying a lot of money, and you call a network clinic, and you find that it takes about 30 days to get in, right? Like, it's not tomorrow, it's about 30 days on average across the country to get in. Right. So you're paying all that money, and and that's probably for an established patient. If you're a new patient in Colorado trying to find a fee-for-service primary care doc on that plan, it may take 2 or 3 months to establish. So you start January 1 paying that money, and you may not be able to get in until March or April to see a primary care clinician here in Colorado. And you get in and see him or her, right? And we like to joke, you spend more time in the lobby than you actually spend with the clinician. And you come in for that preventative checkup, let's say, and you want to discuss a number of things. But the doctor only has 15 minutes of time. So you only discuss maybe 1 or 2 things, and then you've got to come back. But the coming back is maybe another month or 2. So realize you and your employer are paying thousands of dollars for that level of care. And I'm putting that in quotes, okay?
Yeah,
so that is fee-for-service primary care. And then the physician that's in that model, he bills and codes for that visit. And then he and or his system, they do not get paid for probably 2 to 3 months on the service that they provided. So if you think about just very simply as a business model, if you're getting your MBA or you're going to business school, would you ever design a business like that where you do the work and maybe get paid 2 or 3 months from now and you have no clue what you're going to get paid? So there are just so many things wrong with the fee-for-service side, and you got to change it. You got to stop as an employer, as a CEO or CFO. You got to stop doing what you're doing on the status quo, because it's likely the second highest cost on your line items as a company, and you're paying all this money. You're getting, I call it wait in line care. Wait in line, and it just it's problematic on many levels. But if you think about it on the chronic care side, right? These are patients with diabetes, high blood pressure, obesity, mental health issues. Like, those patients ideally, we like to see them or engage with them 5, 6, 7, 8, 9 times per year at least, right? Numerous touches, we call it, or engagements. And if you're on a deductible plan where your benefit plan is only allowing for maybe 1 or 2 visits per year, like 1 preventive checkup per year, you're completely right, Harlan, that the employee's out of pocket for those visits, and the employee now does not come in, does not seek care. And that then results in, for something as simple as a little upper respiratory infection that turns into a pneumonia, or a urinary tract infection that turns into a pyelonephritis, right, does not seek care, so now it ends up in the urgent care or ER. And I said, if primary care worked well in this country, we would not have urgent cares. We would not have urgent cares. The reason urgent cares popped up is because you couldn't get in to see your doctor or didn't have one. So yeah, it's tremendously clear that fee-for-service primary care has been failing our country for decades. And COVID actually pushed a lot of clinics over the cliff. About 1 in 5 primary care clinics closed or sold out to huge entities like huge health systems, or entities like Optum that just bought primary care docs, right? So I guess my point, if we're thinking about it, I anticipate there are probably a number of benefits advisor brokers on this call. You really have to be in tune with what type of primary care is it that you are pitching to the employer group that you're trying to bring on. And if it's a Cigna network here in Colorado, or it's let's say a Buca fee-for-service plan, just know that there are other solutions out there that can provide better care, and it's likely much more affordable to that employee. I'm calling that out directly, Harlan, because I see it time and time again. We've been doing this now on the NextAir front for close to 15 years. And I still see brokers here in Colorado, where there's very Cigna dominant, say, you know what, we're trying to move them from a fee-for-service. Trying to move them from a fully insured Cigna plan to a level funded or to a self-funded plan. And then I ask them, well, who's going to be the TPA? And they say Cigna. And I'm like, oh, come on, guys. Like you're gonna move for them to a self-funded plan, and you're gonna have Cigna as the primary care network fronting that, right? So the point is you've got to look at solutions that are different and arguably better than status quo fee-for-service primary care, and that's a really good place to start. And then you can start to change other things in that health benefit home, whether that's the pharmacy side, whether that's the ambulatory surgery centers that are owned by our physician friends, where you can get direct pay rates for surgery, et cetera, et cetera. So yeah, so kind of got a little long-winded on that, but there are a lot of pieces there, Harlan, that are important, and it starts with primary care. That's where it starts, because that doctor, that clinician can handle 90+% of a person's needs, and you got to get to him or her.
No, absolutely, and that's a great point. I kind of want to go back because you are right. Yeah, as I look down the list of the folks that are here, Clint, there is a lot of advisors here, and if you're here, that means that at least the thought has crossed your mind of changing the design of your plans because you've seen some of the inherent problems. I used to be just like you. I used to sell traditional health insurance because I didn't know any better. The good news is over time, I started learning about these other options and seeing the difference that they make. So I want to go back to kind of what you said just a second ago, Clint, and that is by giving folks, by taking care of the primary care, you're taking care of about 90% of what's going on with that patient. And you're dealing with chronic issues before they get more serious. If you're not using a model like this and you're using a traditional model, all of those costs, and then of course those increased costs later on because of hospitalizations and ER visits and all the other things, that is hurting your plan. That is cost that is coming directly out of your claims bucket. That is causing increases if you're fully insured. That is doing all the negative things to your group, to your employers, and to the employees because everyone's having an increased cost. Let's say that the group decides, hey, we're not going to push anything off to our employees this time. We're just going to accept it. Well, that means that people probably are not getting raises, or else instead of increasing those costs, they're raising deductibles and they're putting even more barriers between the employees and healthcare. So all of these things can be changed by taking the small steps first. But Clint is 100% right. One of the easiest things to do to help your group move along in the right direction is to build your plan around direct primary care by having that place for folks to go and actually get the care that they deserve, and building a relationship with the doctor. Again, it will change the dynamic of your plan dramatically. We are going to start bringing people up to give their comments as well. I see we already have somebody that would like to come up on stage. And so, Elena, we're going to have to go ahead and have you come up and see what your comments are. So come on up here and tell us what your thoughts are on what we have to do. Don't forget to unmute yourself.
Hello, you guys. Thank you so much, Harlan and Clint, to allow me to come onto this platform. I have about 27 years working with the health industry as a fee for service, but not as an insurance provider, more of a billing the actual hospital. So I love the information that you guys are giving, and I can relate to a lot of, those patients having to be put on hold because you have to get that special okay, and sometimes they don't get that okay. Doctors have to scramble to point A and B. So there's a lot of information that's coming. But my question is a little bit different. Coming from an entrepreneur business, I've worked billing a fee for service under the language access umbrella, which is a federal guideline. So we offer like language assessments, translation, and interpreting training. And so those are all key services that several of our hospitals that we've had for a very long time. We do provide that fee for service kind of service for them. But where I can relate to where Clint has said, there's a weight in that billing, even if you're not working with the insurance side in actual hospitals. I mean, we can't necessarily, when we send our invoices regularly, we cannot necessarily bank on when they're going to come in. So maybe Clint can open some suggestions in that area. I know it's a little bit different, but when I saw the fee for services, it attracted my attention. And I thought, if I'm going to ask this question, it's going to be with someone with Clint who can answer that question for me as well.
I appreciate your comments there, Elena. And maybe if we just completely simplify it, right? Like when your plumber comes over to your house, he bills you an invoice. So you could argue that that's a fee for service, and you pay your plumber directly, right? When you start to put a number of different middlemen or women in between that payment and receipt of that payment to your business, that's where things become more challenging. In our world of medicine, there are so many, let's say, people in the middle or admins in the middle that are getting in the way of that payment. So A, the delivery of that payment, but B, they're potentially taking a slice of that payment, right? Like you think about that in the PBM or the pharmacy industry, there's a lot of people taking a slice of that dollar. And so in your case, it sounds like you're billing the hospital directly for services that you're providing. I'm not sure if that is a la carte, like per service, or if that is capitated. Let's say, a certain, amount of money for this amount of services per month. Regardless, this is, if you just want to simplify it, this is why people, you think about the gym membership industry, like Planet Fitness or 24-hour fitness, right? You pay a fee, and for that fee, you can come into the gym as much as you want, and they're not going to charge you extra. And you, as the company, know that you're going to get that fee, or whether a person comes in or not. And then the person that utilizes that gym, it's great for them because they have a fixed amount that they have to pay. So, there are a couple of different ways to think about how are you going to get paid, whether you're a plumber, whether you're a physician, or whether, you're in a service that you provide. And in our case, what we said over time is, gosh, we got to stop being paid per transaction. We can't treat patients like transactions. Let's choose a simple, affordable monthly fee, like a gym membership, and then give our members, we don't call them patients, unlimited access to us. Whether they come in once a month or 10 times a month, or whether we see them face to face or virtually, it's the same fixed fee that allows for fixed revenue versus variable revenue. And so I'm not sure, Elena, if there's a way in your business to do something like that, or if it's even applicable, but I can tell you on the fee for service side for us, that's what we decided to do. And it's been working out super well because we now, have restored, let's say, the doctor-patient relationship, where our patients like what we do, our doctors like it, and employers like it.
Well, thank you so much, Clint, because we do bill patient per patient. And, being the CEO and running my show, it can be time consuming. Get all of those invoices and all those results in. And, we are changing in 2024 some of our business models. And we did think about, suggesting a fixed price for all of our hospitals. That way they can receive one invoice every month versus receiving hundreds of them during the month. So thank you so
Yeah,
much.
there are people, Elena, that have made millions of dollars in that RCM or revenue cycle management business. Gosh, it's I don't know of a physician out there that says, boy, I just love doing fee for service primary care. It's the best thing for me, my business, and my patients. 20 some years of doing medicine in this country, I've never heard a physician say that.
Well,
Hopefully
definitely.
that.
We've been involved in that process now for over 20 something years. And, they kept me up front in COVID. I'm open with all of our education services coming to a stop during COVID. The medical industry literally carried me and let my services remain open and create a virtual platform for just the hospital language access services services that we offer. So I have been trained from the trenches in the medical scene, work with many, many special providers out there. So Clint, thank you so much for allowing me to ask that question and confirm that that's probably what we're going to do in 2024. So hopefully our providers will send me a big smiley when I announce to them the changes coming next year.
Sounds great.
That's good to hear. I'm glad that I think there's too many people and Clint, I like your input on this too. I think there's too many people in that fee for service world, kind of what you said, that have made so much money that just even the thought of it going away sends chills down their spines because of maybe it's a lot of work, but that can be a tough transition, just like it is for doctors, right? I mean, so many of them, it's got to be scary. All of a sudden, you got to step away and you're going to start your own practice. And kind of as you mentioned, you had 2 weeks of business school, right? and what are you going to do? So that's got to be some scary transitions, buddy.
Yeah, and I appreciate you had mentioned that a little bit earlier, Harlan. I appreciate what you said. How you used to do, your health benefit structure a bit different, right? You're probably paid, I assume, from a BUCA, Blue Cross, United, Cigna, Anthem, like a lot of brokers are, right? And there's a parallel there. There's a parallel with what we're doing in fee-for-service primary care. Because remember, I said, I came out of residency, and that was kind of the system I was born in. I was born into that, right? I didn't create, it, but I was born into it. So you just start trudging along, wanting to do what's right for patients and doctors. And then, boy, it became pretty clear that I'm like, we need to do something different. I think it's important to let people know that you've mentioned it a few times. So direct primary care, DPC, which people may have heard of. So DPC is a model of primary care created by physicians that were working in the fee-for-service primary care world. And they say, gosh, we got to do better for our patients. We can't continue to do this. We have to have a different model of business. And so that model, what we called it back in the early days, Harlan, was we just called it monthly membership medicine, because I didn't even know what direct primary care was. So we said, let's start doing that. And we did it right alongside our fee-for-service primary care practice. So we were a hybrid practice. I owned North Vista Medical Centers, which is fee-for-service primary care. And I also owned NextEra Healthcare. And over time, boy, it sure worked out. And very, very, let's say a few years into it, I came across Dr. Garrison Bliss, and he was the physician that coined the term direct primary care out in Seattle. And I'm like, boy, Dr. Garrison, what you're doing, your monthly membership model is very similar to what we're doing. So you're having some success. We're going to start calling ourselves direct primary care. So that's how that kind of, let's say, came to be. But I just want the listeners to know that this model is designed by physicians who saw the problems of fee-for-service primary care and said, gosh, we can do better. We can do better for our patients. We can do better for our businesses. And many of us wanted to remain independent. We wanted to we wanted to own our own primary care clinics, right? We didn't want to work for large healthcare systems. So fast forward to today, fortunately, Harlan, that idea, let's say, has really worked out. And you see direct primary care all across the country, thousands of doctors doing it, many of them owning their own practices. And to your point, owning your own business is not for everybody. And so there are many DPC physicians or clinicians that are employed by DPC practices. So that's kind of the cool thing, right? Like you can open up your own direct primary care practice, or if you don't quite have it, not quite cut out to own a business, you can be employed as a DPC physician. So that is something that, now in 2023, it's kind of fun to look back and see this thing that we just had an idea about really working out. And you take that to next steps. A lot of DPC practices like ours take care of employer groups, and we have the time to be excellent care navigators for those employees. We understand the health benefit design. We understand the setup. Maybe there's an HSA attached. Maybe there's a HRA attached. We understand who the direct pay specialty docs are. Like up in Loveland, Colorado, we have Medora, where we have members from NextEra that go up to Medora and can have an elective procedure for $0 out of pocket. $0 out of pocket for a knee surgery or a back fusion, $0 out of pocket for a hysterectomy, because their employer directly pays for that procedure. It's a bundled rate, and they save so much money that the employee has $0 out of their pocket for that procedure. So again, it's navigating or quarterbacking that care. And in the fee-for-service world, boy, when I was seeing 25 to 35 patients a day, you just don't have the time, and nor do you really even understand the plan that the employee comes in or the patient comes in with. So that's getting a little, deeper into the details and the benefits of direct primary care. But I think it's important to call it out, because if you're a benefits advisor or broker and you're adding things to that benefit plan, the question is, who's going to navigate the patient to those things? And we would say, my gosh, oftentimes patients trust their physician. So do they have a relationship with a primary care physician where they've got that trust and they can have that care navigation happen, and have a team that understands what that health benefit plan looks like? Because every employer has a little bit different benefit plan.
Yeah, that's vitally important. It's funny. I get asked this question all the time. I just got asked it earlier today. Somebody said, "Hey, why did we get a bill for $500 for this? I really thought that this was going to be covered at a much smaller copay." I said, "Well, where did you go?" "Well, where our doctor told us to go." Well, guess what? That doctor doesn't know if that patient's in your network or not. It's really up to you. And so in this case, that's exactly what happened. They actually sent them for a service that was actually more expensive. We were able to help them get that down because the actual build price was $11,000, but we were able to negotiate that down to $500, which is what it should have been to begin with. But the interesting thing is they were sent by the doctor to a place that was not in their network. And they didn't even ask the question because they just made the assumption that the doctor would know. How could they possibly know? That's just what you said, Clint, with all of the different plans out there and all of the different designs out there and all the different networks out there. How in the world could your physician possibly know who's in network? And they're in a more traditional setup. Unfortunately, they're actually, once again, with your favorite kind of plan, Medicare Advantage plan. So they're in a Medicare Advantage plan, and once again, it was to their disadvantage, as you mentioned earlier. All right, my new buddy, Timothy Poor. We just did a podcast together here last week that'll be released later on this month. But Timothy has a very interesting job. He helps folks in their struggles after being hospitalized in many cases. So it'll be interesting to see what he has to say about this. So Timothy, I'm going to bring you on upstage. Don't forget to mute yourself and tell us what you got to say, buddy.
So before I found myself in this role now, I was working with a physicians group though for a hot minute, and this is back in probably about June of 2019, and we started developing a similar type of direct primary care model, but this was actually for employers, and and essentially it would be a membership plan for employers, and they would pay per employee, especially for small companies, and they would allow them to provide, a decent type of like health coverage. And really what it is to do is it was designed to help assist families in making sure they come to work, right? So the first target was our local hospital. And it is a 155 bed hospital, and the, one of the issues that they had though was they had a lot of employees that were missing work due to children at sick or something like that, and someone having to stay home or whatever it is, or they couldn't have. They had a lot of sick call-outs essentially, and that happens a lot with health systems. But we said, well, we have like a membership fee, and it's if your guys are okay with telehealth, we can sit there and say, hey, we can kind of do an examination and say, yeah, we can, pick up the prescription at such and such place. They'll be ready for you and for your child or for you, and just go on your way, so that the family doesn't have to worry about getting a doctor's appointment or anything like that, scheduling that sort of stuff. And we also worked with a lot of, because it's Florida, a lot of construction companies, and saying, hey, we can help tell you whether or not it's actually cocktail flu or if it's actually something that's going on. And we actually had a few few groups that were signed up. It was doing halfway well until about Well, let's see, get rolling around January of 2020. So I don't know what it is that possibly could have made things a little more challenging for it, but it was actually picking up pretty decent momentum. It was an interesting idea. I kind of want to see what your thoughts were on that, if you're seeing that in other sectors, because especially for health systems, because they do rely so much on labor, like your CNAs and that sort of stuff. And typically, if you think of a CNA, they're struggling with a lot of things, and healthcare for families is something that obviously can be a bit of a challenge for them.
Yeah, I appreciate your comments, Timothy. There, you kind of brought up a number of things that got me to thinking. So, we take care of, as you look at the pie of who we take care of at NextEra, about 90% of our members come from employers. And some of these employers are small companies, HVAC companies, plumbers, electricians. Some of them are larger municipalities, larger school districts. Some of them are Fortune 500 companies, right? So it's kind of a spectrum of employer groups. And I'll tell you, the common thread across those employer groups prior to us taking care of them is they were all in fee-for-service primary care, and they weren't satisfied with the amount of money they were spending, both the employee and employer, and they also weren't happy with their care. And that led to, a number of things. You kind of touched on a bit, like absenteeism and presenteeism in the workplace, right? You wake up in the morning, your kid has pink eye, and so your kid doesn't go to school, and you don't go to work, and you got to go to an urgent care or an ER, right? Like all these things that cascade when you are fronting a benefit plan with insurance-based fee-for-service primary care. And so as a, let's say, CHRO or HR director or a CFO or CEO or the owner of the company, it's really important to be in tune with what are you paying for and what are you getting. And your most valuable asset as an employer is the employee, right? And so a lot of pieces that you've got me thinking about a number of different things with your comments. And as I look at the past number of years and the impact that DPC can make for an employer group, those employees and their family members have same-day access for urgent issues where they can get into their doctor or clinician same day, either face-to-face or virtually. And on that virtual piece, it's important to call that out. This is not Teladoc. It's not Amwell. This is virtual care with your doctor that you know and trust, not a doc in a box that's 3 states away. And that's really important, right? Because if you're getting virtual care from somebody you don't know, that doesn't work out as well versus virtual care from your physician that can also have continuity with you and actually bring you back into the clinic, let's say tomorrow or the next day. The other piece that we've done over years is we have both near-site and on-site clinics. And so for some of our employer groups, we actually have clinic on-site where that employee can come out of their cubicle, come see their physician, and then head back into their cubicle. So now imagine the efficiencies of that, especially if you're the COO or CFO of that company where the employee's getting care. And then remember that the employee gets that care and there's no cost per visit. So you don't have that financial barrier. There are a fair amount of virtual care companies out there doing virtual care only where there's a cost per visit. In our case, with DPCs across the country, there is no cost per visit. And I think it's important to call out, like that average direct primary care fee is around $70 to $80 per member per month. And if you think about what the average plan cost is, the premium per month, oftentimes that DPC fee is less than 10% of the total premium. But it's affecting the full spend, as Harlan has mentioned. So, I don't know that I maybe answered your comments directly, but your comments just had me thinking about a number of different things. There are many different companies out there, especially with COVID, that are saying a variety of things, right? On the virtual care front, they're trying to, use AI. They're trying to, make pods where you can go to a mall and sit in a pod and have AI and a virtual doctor see you and all that jazz. Like, Oh gosh, good luck. Good luck with those things. At the end of the day, just make it simple. You got to have access to a primary care clinician that can handle most of your needs and do so in an affordable way. And if you do so, there's going to be all kinds of pretty cool things that happen. And as a patient, it's going to impact your morbidity and mortality, but it's also going to impact your spend. Like it's going to impact the amount of money coming, that you spend for your lisinopril or your Crestor or your, physical therapy or your elective procedures. So make sure you get to that quarterback that can handle most things for you and do so in an affordable manner.
Yeah. The other thing I just kind of want to mention though is also the community that I'm currently in is in the startup community, and one of the issues we've kind of faced, as a lot of startups will face, is that provider of health insurance to potential employees that you're trying to recruit or snag away from another company or whichever it may be, and often. One of the roadblocks that I would face early on was, but I have a really great health insurance plan. And I'll say that's also an area that direct primary care can really jump in and make a huge impact. I believe it is addressing that sort of like that transition point, saying, hey, you may have a great plan, but can if you're a startup and you can go to a potential employee and say, yeah, you may have a great plan, but can your provider see you that day if your kid is sick or whatever it may be? How much time are you going to have to take off work? And by the way, can you just work from home? Still, and that's like sort of like areas that makes things that agility of a direct primary care adds to a system is I think very beneficial.
Yeah. I hear your comment there on, I think I have a really good health insurance plan. Said hashtag nobody ever, right? Like let's peel off the layers of the onion there, right? Like, we joke about, hashtag PPO gate. Like these people and employers are spending, earlier I mentioned $13,900 a year for a PPO plan where you can't see a doctor for a month or two. So they're almost in this, Stockholm syndrome type lane where they because they're paying so much, they think they're getting a lot, or because their employer's paying so much, they think they're getting a lot. I would highly encourage you all to go to Stacey Richter's Relentless Healthcare Value podcast and listen to Mark Cuban talk recently about PBMs. Like, it's a gold mine of information.
Great,
and
yes.
these people they're lulled. They are lulled into the fact that they think that this expensive insurance card is health care, and it's not. These entities are multi-billion-dollar businesses, and the health systems around us, like the ones we have here in Colorado, they are financial institutions that are very profitable. Okay, so go back to what I said earlier, and that is care doesn't happen without clinicians. And who is your physician employed by? Is he employed by a big health system? If so, your costs are going to be higher. How are you accessing that physician? If you're using your deductible plan with Cigna, or your United plan, or your TPA is UMR or Cigna, you are paying more for that elective procedure than if we were to do it direct pay. And typically that is 30, 40, 50, 70% more. Okay, so Harlan kind of tuned into this a little bit earlier. People think, well, my gosh, if I use this card to get this procedure through my PPO plan, I'm going to pay less, or I'm going to get a 50% discount. Well, it's a 30, 40% discount off a 500% markup. So if we actually drill down to, well, what's the cost for that hysterectomy at the physician-owned ambulatory surgery center for this elective procedure, where you paid for that bundled hysterectomy that includes all of the anesthesia, facility fee, and the surgeon, boy, that cost can be, X, not 3X through your PPO plan. And again, if you're a self-funded employer and your TPA is UMR or Cigna, you are going to pay more for those elective procedures, you as the employer. And so I'm kind of getting into some fine detail there, but you got to be super sensitive to how are you getting that elective procedure. Most of the things that doctors write orders for happen outside of a hospital. Okay, most of the things that we write orders for, meds, imaging, labs, elective procedures. So the question is, what is the direct cost of that? And that's the beauty of entities like the Free Market Medical Association, or what Health Rosetta is doing, and what Keith Smith pioneered down in Oklahoma, that, direct pay rates. And then what is critical in that point is having that DPC physician healthcare team know where to send you for these things. Because oftentimes you may think, well, gosh, I'm going to get my medication through my Optum or my Caremark or my Express Scripts because it's part of the formulary and part of the plan. That is costing you as the employer or you as the employee way too much money. So be smart as a consumer, whether you're the patient or whether you're the CFO, and you just can't continue to do things status quo. So it got me off on a bit of a rant there, Tim, but part of that was because you said, boy, I'm really excited, or I'm really happy with this health insurance plan that I have. Let's peel off the layers of the onion there. How much does it cost? Is it that $13,000 or $14,000 a year? And if you get with some of these savvy benefits advisors out there like Josh Butler down in Amarillo, or Ben Connor and Harlan, and these benefits advisors that know how to put a good plan together, oftentimes the cost per employee per year is half of that $13,900, right? And you're getting an unbelievable amount of care. And it's accessible, it's convenient, and it's affordable. And so I really appreciate your comments, Tim. And boy, I could talk for about another hour on that kind of design and benefits.
Hey, and Clint, I want to hit on a couple of things. We're just about at time here, guys, but I want to wrap this up with a couple of things, kind of go back to what you said. First of all, the people that really love their health insurance plan are the ones that typically don't have to pay anything for it because the employer pays for it and they've never had to use it. So those things can make your plan just awesome. It is a great plan whenever you've never had to use it. Or maybe you've been one of those lucky people that when you went through everything, it went like clockwork. That does happen sometimes. Doesn't happen very often, but it does happen sometimes. The other thing is you mentioned that when you start dealing with big insurance companies and healthcare systems, and there's lots of negatives there. Well, this is a cautionary thing. I know you've heard about this as well, Clint, and that is the direct primary care name. That model is not necessarily anybody's. So it has been used in various different ways. One of the newest things that has happened is some of these large hospital systems that are tagging that name onto some of their primary care services. And they are a model that is out there. So they're saying, hey, here we are, we're XYZ system, and we offer direct primary care. It is not going to be much different than what you're getting already. They're still going to be funneling people into their system. That is all part of the game that they're playing. So just a little bit of a cautionary tale out there. Be sure to understand that not all direct primary care in name are created equal, and that there are some really good ones out there. But here is what I have learned from my friends that are in this industry. If you ever question whether a direct primary care doctor is going to be, have the same aligned incentives as you and is a good person to work with, I promise you, Clint and a lot of the other ones that are out there in it, Dr. Jeffrey Gold, Dr. Roger Machagumbo here in San Antonio, and just tons of other ones that are out there, they're always willing to talk to you. They understand that it's going to take all of us to make this change. And they want to make sure that the folks that you're working with are going to give your clients the best service. So the best way to find out if a direct primary care doctor is a good direct primary care doctor is to ask one of these guys. And that comes directly from those doctors. When I've asked those before, even in large group settings, all of them say the same thing. Ask us. Somebody somewhere is going to know this person and know whether they're going to be a good fit for what you're looking to do. So that's kind of some of my parting advice on this. I highly recommend building plans around direct primary care, advanced primary care, those membership models. They do a couple of things. First of all, they provide much better care. And remember, anything that happens in those settings does not come out of your claim bucket. So you're saving your plan money. And of course, on top of that, you're providing, and this is actually the big key, you're providing much better access to health care for your employees and the other members, and of course their families as well. All right, any closing thoughts, Clint?
Well, Harlan, I just appreciate everything you're doing and appreciate the platform here today. And, you see all these grass fires happening across the country, groups of people getting together and doing the right thing for employer groups, which results in the right thing for the employees and their communities. And boy, it's just tremendous. I wish there were many grass fires, a decade plus ago when we were down this pathway. But these things take some time. You just keep turning the flywheel, and there are a lot of good people doing awesome things all across the country, and you're one of them. So really appreciate the platform, and yes, as Harlan mentioned, happy to be a source for any of y'all out there. Feel free to reach out to us at NextEra Healthcare, and happy to have a chat and excited about the next 5 to 10 years because we're all making a difference. And this is important stuff because it's people's lives, right? And it's employers, and those things are really important to us.
Yeah, absolutely. It certainly is. Certainly is. Once again, thank you so much for being with us today and sharing your wisdom. Clint, I sure appreciate you taking time. I know it's a busy time for everyone. Timothy, thanks for coming up on stage. Alana, thank you so much for your comments earlier as well. And don't forget, folks, this will be available. The recording will be available later. If you didn't get to hear all of it or you want to share it, it will be out there, posted here probably within the next 2 to 3 days. And then also, if you want to catch up with what's going on in our world and who knows who you'll hear next, be sure and listen into the Health and Wealth Power Hour. You can go out to hwpowerhour.com and check out all of the episodes. Appreciate everyone being here, and we'll catch you next month. Everyone have a super blessed week, and we'll catch you next time.